Hello, I'm Hematologist Oncologist Dr. Talebi. Today we're going to discuss the management of prostate cancer that has become resistant to testosterone therapy. I have the pleasure of being with Dr. Rakesh Sengel, Associate Professor of Medicine at University of Miami, and a very distinguished prostate cancer specialist. Thank you for being here.
Thank you, Dr. Talebi, for inviting me.
Thank you. So let's assume a patient has prostate cancer and they have been on anti-testosterone therapy, either with injections or they've had their testicles removed surgically. Now the PSA is starting to rise and the patient gets referred to you. What happens next for that patient?
So this is a very common scenario for patients with prostate cancer, that after they undergo local treatment and then in the form of radiation or surgery, many times their PSA starts rising, and we see it very commonly in clinic. So the first thing in that situation is to determine if it is only the PSA that is going up, or if they have effect of cancer anywhere else on the body. And the way we determine that is by doing a CT scan and bone scan commonly. Many times patients such patients have symptoms related to bone pain and other symptoms, so these investigations are useful anyway to determine if symptoms are related to the spread of prostate cancer. But the first thing that we want to determine is if it is only PSA going up or prostate cancer has started affecting the organs and bones in the body.
I see. Now what if only the PSA is going up and the imaging shows that you can't see cancer anywhere else? What happens for that patient?
So in that patient, usually we try some other kind of medications. There is a group of medications called as anti-androgens, and these are such as bicalutamide, flutamide, nilutamide. So we try to control cancer through these medications. Most of the newer treatments, however, have come up in patients who have metastatic disease or if the cancer has spread to other parts of the body. Part of the reason is we don't know how long it is going to take in a particular patient for cancer to show its effect on the body. So we try to continue with a gentle treatment earlier on while PSA is going up and they have no evidence of effect of cancer in bone scan or CT scan.
Mm-hmm. There's a concept that's very important to you all called PSA doubling time. Mm-hmm. Would you please explain to our patients what that is?
So PSA doubling time is the time it takes for PSA to double from what their level is. So in patients who have a short PSA doubling time, that usually indicates a more aggressive cancer. And patients who have a long PSA doubling time, they usually indicate a more indolent type of cancer. It is one of the factors that we use in defining treatments, and it is one of the things that we consider overall in addition to patient symptoms.
Now let's say the PSA was going up and you do the scans and you pick up new cancer in the bone. Mm-hmm. What happens next for that patient?
So yeah, this is a very exciting time for prostate cancer in terms of management. Until a few years ago, we did not have any treatment that could prolong survival or improve survival outcome in these patients. So there was the chemotherapy drug approved for the first time, I believe in 2004, that showed improvement in survival in these patients. And this drug is Taxotere or docetaxel chemotherapy. However, in the last 2 years, we have several additional medications that have been shown to improve survival now. And these are, one is the hormonal therapy called as Ebinetron. The second one is a vaccine called as Provenge. And the third one is another type of chemotherapy, Geltrana or Cabaxin.
I see. So if the patient is already receiving the anti-testosterone injections once every month or 3 months, do they need to continue that or do they stop that?
Yes, I think they should continue with that. And the reason is we know that testosterone is very important to fuel prostate cancer growth. The newer medications that are coming up, they really lower testosterone level to almost nothing, and they have been shown to be effective in patients with prostate cancer. So in view of the important biological of the prostate cancer, which is fueled by testosterone, if we do take patient off these hormone injections, their testosterone will go up and they will likely progress faster.
Mm-hmm. What about the patient's performance status? How the patient's doing overall? Does that change what management you render?
Yes, it does. And patients, the performance status will help us decide which way to go in terms of the chemotherapy in treatment. So in patients who have a good performance status, I tend to opt towards chemotherapy, or hormonal therapy, or the newer agents such as Ebinetron can also be used. But in patients who have a poor performance status, then either we have to devise a different way of giving chemotherapy, or lean more towards the hormonal treatment, which is better tolerated in patients with poor performance status.
I see. Pain is often a very common symptom in patients with prostate cancer. How do you address the pain?
So we have very good ways to take care of pain nowadays. So we understand in patients with prostate cancer, pain is a major symptom, and usually when we start patient on treatment, such as chemotherapy or the newer treatment, their pain does come under control. If, however, they continue to have pain, then local radiation to a particular site also helps in control of pain. If a patient has diffuse pain, then we can consider what we call is a radioactive pharmaceutical, such as samarium or strontium.
I see.
Also to understand is that we continue to adjust their pain medication throughout their treatment. So that also helps in controlling pain from the symptomatic point of view.
I see. There are these new bone-protecting agents called either the bisphosphonates or denosumab. What is their role in prostate cancer?
So they have an important role to play. We know in prostate cancer, bone is a major site of spread of cancer. And spread of cancer to bones can lead to certain complications. And these are such as fracture of the bone, requirement of radiation to bone, spinal cord compression. So these skeletal related events or the bone related events are reduced by patients going on these newer medications such as zoledronate or zoledronic acid or denosumab or Xgeva. So the clinical trials have shown that patients who are treated with these medications, they tend to have a lower incidence of complications related to spread of cancer to bone.
I see.
And in addition, that some of these agents can also help in reducing pain related to bone metastasis as well.
I see. Oftentimes patients are interested in taking alternative herbal medicines. What do you say to that when concurrently with your treatments?
So that is a difficult question to answer from the point of view there are no clinical trials to my knowledge that have looked at that. But I commonly tell my patients that if they're on chemotherapy to avoid taking alternative medications because some of these alternative medications may have antioxidant, and one of the ways chemotherapy works is by causing oxidative damage. The other thing is many of these alternative medications may interact with the treatment that I'm giving them, and since they have not been well studied in regarding the interaction between alternative medications, so we are not sure what kind of side effect patient can have when they take those medications in addition to chemotherapy.
I see. You mentioned one therapy called Provenge. Would you please explain what that is, how it's administered, and do you recommend it?
Okay. So this is the first vaccine that has been approved for the treatment of cancer. Provenge is also what we call as immunotherapy. In this, there are white cells. They are taken from the patient's blood. They are sent to a central facility where they are stimulated with a compound, and then they are sent back for infusion in patient. So 3 infusions and given at 2-week intervals. So this treatment has been shown to prolong survival in patients with castration-resistant metastatic prostate cancer, the patient group that we are talking about. patients who are good candidates for this treatment, they have no pain or very mild pain. They are not on narcotics for pain medication. They have bone metastasis. One thing to remember is that it does slow down the rate of growth, but we do not expect PSA to go down with this treatment. So PSA goes down very rarely, and I understand that we in prostate cancer we look at PSA closely, and many patients look at PSA numbers closely, but it is important to remember that in patients who are treated with Provenge, we do not look at PSA number as such because it may not go down at all. So I do recommend this treatment in patients who have asymptomatic or mildly symptomatic prostate cancer, who are not on any narcotic medications, who have bone metastasis, and who have a rather slowly progressive disease.
Wow. And there's a new pill called Abiraterone. Where does that fit into your treatment?
So Ebinetron is a novel treatment, and the way it works is it blocks production of hormones, not only from the testes but also from adrenal gland and within the prostate cancer cells. So it is interesting that the novel scientific research has revealed that even though by hormone shot we can block production of testosterone from testicle, but there are other sites in the body which continue to make hormone, and these are adrenal gland, as well as the recent research has shown that prostate cancer cells, they can themselves make their own hormone. So Abiraterone works by blocking enzymes that are involved in synthesis of these hormones. So it decreases hormone production from testes as well as from the adrenal gland and within the prostate cancer cells. So far this medication has been studied in patients who have received prior chemotherapy and have progressed after that, and it has been shown to improve survival in that group of patients. So we commonly use this treatment after docetaxel chemotherapy. Now there are ongoing clinical trials that are using this medication before chemotherapy also, and depending on the results of those clinical trials, we may start using it earlier during the stage of the disease.
I see. What common side effects have patients been experiencing with this Abiraterone?
So Abiraterone is not a chemotherapy medication. It is fairly well tolerated. The main side effects that are related to Abiraterone relates to its mechanism of action, and it can cause side effects like fluid retention, it can cause hypertension, and it can cause low potassium in the blood. So these need to be monitored very carefully. Also it can cause changes in the liver tests, so those need to be also monitored carefully. The other side effect to note is that sometimes it can cause body aches and flu-like symptoms.
I see. You mentioned a chemotherapy called Taxotere, which is so important for prostate cancer specialists. What is that, and what are the side effects of Taxotere?
So Taxotere is a very important drug for patients with prostate cancer. It is the first drug that has been shown to improve survival in this group of patients. So there are two ways to use Taxotere in clinic. The better way to use it once every 3 weeks, and that is the regimen that has been shown to improve survival. Sometimes, however, if patient has a poor performance status, and we do use them on a weekly Taxotere that is fairly well tolerated as compared to every 3 weeks, which has more side effects. So the side effects of Taxotere relate to its action, and these are common side effects are the nausea, rarely vomiting. It can lead to hair loss. Sometimes it's called diarrhea. It can also cause a neuropathy like numbness and tingling in hands and feet. Also, it has a side effect of an allergic reaction that can happen with infusions. So patients are commonly given steroids or dexamethasone prior to coming for Taxotere infusion. The other side effect to remember is that it can lead to a lowering of the blood count, and one of the important side effects is really it can cause neutropenia or lowering of the white cells that can fight infection. So if patients have a fever after Taxotere, then we commonly recommend them to seek emergency to go to the emergency room for medical care, because infection can be life-threatening in that situation.
I see. What about this fairly new chemotherapy, Cabaxin? How do you use that?
Cabazitaxel is also a chemotherapy that is given intravenously. It is given on a schedule of once every 3 weeks, and it has been shown to improve survival in patients who have been previously treated with Taxotere and has progressed on or after that treatment.
You mentioned another treatment, Strontium 90. What is that and when do you use it?
So Strontium 90 and there is a relative compound called as samarium. They are what we call as the bone targeting radiopharmaceuticals. So this is a way of giving radiation that goes to bones and tries to control prostate cancer by killing prostate cancer cells in the bones. So we commonly use them in patients who have who had a diffuse spread of cancer to bones, and they have pain related to those bone metastases. So these medications help in controlling bone pain in those patients.
I see. Do you recommend exercise for your patients while they're undergoing treatment?
Yes, I do recommend exercise. Exercise keeps them in a good shape, but they have to be careful. One of the issues in patients with prostate cancer is they can develop osteoporosis due to hormone treatment over a long period of time. So I do recommend checking their bone density periodically to make sure they are not at an increased risk of fracture. Because if they have osteoporosis and they are not careful about it, they can have fracture of the spine or of the vertebra or of the femur, and that could be very problematic. So on a similar line, patients who do have osteoporosis, they can be helped by newer treatments to improve their bone density. So it is very important for patients who are on long-term hormone treatment to get themselves checked for this side effect of hormone treatment as well.
Very nice. What if the patient complains of not having any appetite? How do you address that?
So yes, that is also one of the issues that we see in our patients, and I want to find out why their appetite is low. Many times when they have not started treatment or they have progressive disease, then once we start them on treatment and their disease comes under control, their appetite comes back. However, at our later stages of disease, when there are no good treatment options, and sometimes that can happen if they've gone through all different treatment options, that is a sign of progressive disease. In that situation, we do discuss treatments like the appetite stimulant, and I do discuss the side effects of those medications as well. And depending on patient wishes, we do prescribe in sometimes appetite stimulant in those conditions.
I see. How do you follow to see whether your treatment is working or not? How do you know?
That's a very good question also, and there are different ways of knowing if a treatment is working or not. The first of all, the patient, if he has bone pain, so the first indication of treatment working is that patient himself would note relief of bone pain after being started on treatment. If patient does not have pain, then there are other measures by which we know if the treatment is working or not. There are blood tests that we can do to monitor the effect of treatment. I think all patients with prostate cancer know about PSA. PSA usually goes down when treatment is working. But there is a new test and where we can count the number of cells in the blood circulation. And this test is called as circulating tumor cells. So we can periodically check the number of those cells in circulation, and if their number is high initially before starting treatment, and if that goes down, we know that is a good sign, indicates the treatment is working and they're likely to do better. In addition to those things, we periodically repeat their CT scan and bone scan. Now, bone scan is commonly interpreted to see if patients are developing any new lesions. Because the existing lesions on bone scan, they usually remain as it is. So we rarely see any healing of bone lesions in patients with prostate cancer. So we monitor bone scan from that point of view, and on CT scan if they have any evidence of disease in the lung, liver, lymph nodes, so we can monitor the size of those lesions to see if the treatment is working or not.
How do you handle the very difficult discussion of whether this is curable or not? And how do you handle the situation when the family doesn't want you to tell the patient what's going on?
That's again a very important question. So in terms of the first question about, I usually tell patient on their first visit itself, if I do find they have if they have a local treatment and their PSA has come back and they have spread of cancer to other parts of the body. So I do tell them that the disease is not curable. However, I do clearly tell them, even though it is not curable, we have treatment options now that we did not have a few years back. So, and these treatment options can prolong their survival. So I do tell them about that. The second part of the question is if family wants, I do not feel that it is ethical. I do have a clear discussion with patient, because it is patient who is going to make decision regarding what treatments they are going to go through and to what extent. So I usually have a clear-cut discussion with patient. However, if patient is not competent, in those situations I do discuss with family about all the next of kin or a medical care surrogate about the treatment option and what would be best for that particular patient.
I see. Would you please explain what a clinical trial is and whether you recommend that in prostate cancer?
So clinical trials are very important for patients with, I think for all patients with cancer, and especially for patients with prostate cancer, because that's how we know a certain treatment is effective or not. So I always recommend patients, if they are suitable for a clinical trial, to consider that. Again, it is patient's perspective whether they do want to participate or not, but I strongly encourage them to at least consider a clinical trial for their particular type of situation.
I see. So when do you get to the point where you would recommend palliative care or hospice for a prostate cancer patient?
So if a patient has advanced disease and we have run out of treatment options, so that is one of the situations where we consider hospice or palliative care. Also, it's many times depends on patients' wishes also. Sometimes they may not have run out of treatment options, but they may not wish to undergo chemotherapy. So we do consider it at that time also.
Well, thank you so much. This has been great. Thank you for watching. We hope this has been educational for you.